All right, let's dive right into this explainer. Today, we are unpacking the absolutely critical, though often totally unseen, role of opioid treatment inside Washington, D.C.'s correctional facilities. You know, when we think about the justice system, public health usually isn't the first thing that comes to mind, right? But as our source material reveals, what happens medically behind those walls, and crucially, what happens right at the release gate, is quite literally a matter of life and death.
So, to wrap our heads around this complex issue, we're going to break it down into 5 quick parts. First, the risk behind bars. Second, understanding MAT in custody. Third, inside DC's treatment scale. Fourth, the federal and local maze. And finally, bridging the reentry gap. Let's get into it.
Section 1. The risk behind bars. So what actually happens when individuals with an opioid use disorder enter the justice system?
The source material lays out a stark biological reality here. When people who use opioids are incarcerated, abruptly stopping doesn't just cause insanely painful physical withdrawal inside the jail. It actually creates a massive public safety and health hazard for the outside world. Why is that? Well, untreated addiction behind bars severely elevates the risk of relapse. Think about it. When a person's tolerance drops during incarceration, their body completely resets. So returning to that same exact level of use after release isn't just risky, it's incredibly dangerous. Those weeks immediately following a person's release, they are highly vulnerable and carry an extraordinarily high risk of fatal overdose.
Which brings us to Section 2, understanding MAT in custody. Fortunately, the medical and correctional fields are partnering up to tackle this exact risk head-on.
The absolute core of this partnership is something called medication-assisted treatment, or MAT. And honestly, this brilliantly illustrates modern correctional healthcare. MAT combines FDA-approved medications, specifically things like methadone, buprenorphine, or naltrexone, with mental health counseling and robust recovery support. It's basically about treating the whole person to reduce withdrawal, prevent relapse, and ultimately avoid death. It's kind of a surprising reality, but correctional settings are actually often the very first place someone with an opioid use disorder is successfully identified, stabilized, and connected to real evidence-based care.
Now, you might have heard people say that MAT is just, replacing one drug with another. Well, according to the experts, that is a dangerous stigma. Public health agencies firmly treat MAT as proven, evidence-based medical care. It's a highly targeted medical intervention. They're definitely not just swapping dependencies. By treating the addiction as the severe health issue it actually is, the system is actively working to prevent repeated incarceration and, most importantly, save lives.
All right, moving on to Section 3, inside DC's treatment scale. So how is this theory actually being applied on the ground in the district?
If you really want to know if a program is working, you have to look at the scale. And D.C. Department of Corrections performance oversight testimony reveals a staggering number. An average of 500 residents are on medication-assisted treatment each and every single month. That officially makes the D.C. DOC one of the district's absolute largest single providers of MAT. They aren't just dabbling in this as a little side project. No, they are operating as a massive central hub of addiction treatment for the entire city.
And to really see where this is heading, just consider the trajectory. The DOC effectively doubled the number of MAT participants from the prior year. Doubled. This isn't just some pilot program slowly finding its footing. This tells us that MAT is an integrated, indispensable part of the agency's core health response. They are treating addiction as an urgent public safety and health priority and rapidly scaling up their resources to meet the real-time demand of the population.
But listen, this is way more than just a dispensary window. The DC DOC operates as a fully recognized opioid treatment program. They hold some pretty significant official accreditations through both SAMHSA and the National Commission on Correctional Healthcare. On top of that, they've established specialized therapeutic housing units for both men and women. These units actually utilize a curriculum that is explicitly trauma-informed and gender-responsive. They are essentially building a dedicated, highly structured environment for recovery right there inside the detention facilities.
Medication is really just one slice of a much larger holistic pie. Look at how DC approaches this ecosystem. They pair those medical providers, who specialize in addiction medicine, by the way, with mental health clinicians, peer navigators, and grant-funded empowerment programs like RSAT. By surrounding residents with this comprehensive, multidisciplinary support system, they aren't merely managing physical withdrawal symptoms. They are actively preparing these individuals for long-term recovery and their eventual successful reentry into society.
Section 4. The federal and local maze. Because treating individuals in Washington, D.C. comes with a very unique and honestly highly bureaucratic complication.
You see, D.C. is both a city and a distinct jurisdiction, which, as you can guess, creates an absolute logistical nightmare for healthcare.
While the local D.C. Department of Corrections manages the initial intake and local incarceration, many sentenced D.C. Code offenders are eventually transferred to the Federal Bureau of Prisons under federal law. This transition is incredibly risky. Moving from a local jail to a federal prison is kind of like trying to transfer your medical records to a different planet. It threatens to fatally interrupt a resident's treatment, their prescriptions, and all their ongoing progress. If that continuity of care breaks during the transfer, the individual faces immediate, severe withdrawal.
To keep a watchful eye on this complex jurisdictional shuffle, D.C. uses an important oversight body called the D.C. Corrections Information Council, or CIC. The CIC actively monitors conditions across both the local DOC facilities and those distant federal facilities where D.C. residents often end up. Their ultimate goal is to ensure that individuals don't just fall through the cracks during these major transfers. They advocate to make sure that access to MAT and continuous care isn't suddenly lost just because an individual crossed an invisible bureaucratic boundary.
Which brings us to our final part, Section 5, Bridging the Re-Entry Gap. What actually happens when someone leaves the correctional facility and steps back into the community?
True success in addiction treatment isn't just a single event, right? It's an unbroken chain of continuity. It starts with rapid screening at intake, moves to stabilization and specialized treatment while in custody, requires thorough reentry planning, and critically, it must hand the individual directly over to community health networks upon release. If any single link in this chain breaks, the whole system fails. Correctional MAT is ultimately only as effective as the community network it connects to on the outside.
Fortunately, the district has a robust public health infrastructure waiting on the outside to catch these individuals at the gate. Agencies like DC Health and the Department of Behavioral Health are deeply integrated into this whole process. They provide ongoing MAT services, counseling, and in some cases, residential care. Crucially, they also heavily lean into harm reduction programs, including widespread naloxone distribution. This coordinated handoff ensures that when someone leaves custody, they have immediate follow-up care and the vital tools they need to survive those incredibly high-risk early weeks.
So, what should we really take away from all of this? Well, the source material makes it undeniably clear. Medication-assisted treatment in DC is no longer some niche idea. It's a massive, core public health strategy happening at a highly meaningful scale. But as we wrap up this explainer, we are left to ponder one final provocative question. Can the system flawlessly maintain this life-saving continuity across every single facility transfer and every single community reentry? The groundwork is impressively laid, but in a sit where incarceration and overdose risk intersect so sharply, that unbroken continuity is exactly what will determine if these efforts truly save lives.